Hi everyone, my name is Callie Purevdorj, and today I'll be sharing my applied practice experience in my APE, which I completed at Ballard Dental Arts in Seattle, Washington, which is my current workplace. I'm a student at Eastern Washington, and this is for my public health class 601, my last class. I'm so excited. And my professor's name is Dr. Shavonda, and my mentors and my supervisor name at BDA was Dr. Tobler and Ernie Erickson, which is my office manager. This practicum was an incredible opportunity to bridge classroom knowledge from my master's in public health program with hands-on community-based work in the dental field. My site supervisor provided ongoing mentorship and allowed me to take ownership of major components of the project, from needs assessment to intervention design to evaluation. Through this APE, I developed a mixed methods needs assessment, created culturally tailored health promotion materials, and designed educational resources for both caregivers and children. The target population included linguistically and culturally diverse families, many of whom face barriers preventing dental care. My goal was to not only provide resources, but also to ensure these resources were accessible, engaging, and culturally relevant. One of the first steps was recruiting community health workers who were fluent in Somali and Spanish. And I also asked around many of anybody who was at my workplace who spoke another language, but mostly Somali and Spanish. These individuals served as cultural brokers, helping bridge communication and trust gaps between the clinic and the community. I also had access to university resources, including survey methods, support, licenses for SPSS, and in vivo, which allowed me to analyze both quantitative and qualitative data effectively. We developed and palette tested a caregiver survey with 10 families to ensure clarity and cultural appropriateness. Based on the feedback, we refined terminology and added pictorial prompts for participants with low literacy levels. This careful preparation ensured that the data collected was both accurate and meaningful for guiding intervention design. After finalizing the survey, I moved on to the preparation phase for data collection. This included organizing survey logistics, confirming community event schedules, and coordinating with interpreters and cultural brokers. I also created protocols for surveys that would be administered to maintain consistency, cultural sensitivity, and data accuracy. This groundwork was essential because it ensured that when we entered the community, we could focus entirely on building trust and gathering qualitative responses. After finalizing the survey instrument, the next step was to get into the field and begin data collection. Over the course of 4 weeks, I administered 108 caregiver surveys at a variety of community events. These events were strategically chosen to reach families from our priority populations, including Somali and Spanish-speaking communities. In addition to the surveys, I conducted 5 semi-structured interviews with key informants, including faith-based leaders, school administrators. Their perspectives provided context to the quantitative data, helping us understand not just what the barriers were, but also why they existed and how they could be addressed. From this information, we co-developed a culturally tailored oral health toolkit. This included brochures in English, Spanish, Mongolian, and Korean, as well as interactive lesson plans for elementary school classrooms. I collaborated closely with school nurses to ensure that lesson plans were aligned with existing health curriculums and with a graphical designer friend to make sure that the materials were visually engaging and literacy appropriate. We also scripted, filmed, and refined a 3-minute instructional video aimed at caregivers that were taken on the phone. This video went through multiple rounds of review and was adapted based on community feedback to ensure it resonated culturally, used clear visuals, and offered actionable oral health tips. Altogether, these activities provided both the evidence base and the resources needed to move forward with an intervention that was practical, culturally relevant, and ready for community use. For competencies C2 and C9, I designed and validated a mixed methods assessment using the oral health literacy framework. Quantitative survey data was analyzed in SPSS, while qualitative interview transcripts were coded in vivo to extract thematic insights. I applied the health belief model to the toolkit materials, emphasizing self-efficacy and perceived benefits of preventative oral care. I also integrated social cognitive theory into the lesson plans by using peer modeling, children learning from other children, because evidence shows this improves engagement and retention. A logic model was built to connect inputs, activities, outputs, and expected outcomes. This was critical for me for guiding both implementation and evaluation. To ensure the project stayed on track, I used a facilitated checklist, real-time audits, making adjustments as needed. Finally, I helped establish a community advisory board to co-design outreach strategies and successfully secured a partnership with the county health department for a mobile dental clinic pilot in the near future. For competencies C11 and 13, the focus was on creating accessible, culturally appropriate materials. The brochures used plain language, photographs, and culturally resonant imagery to make oral health concepts easier to understand. Lesson plans were designed to engage different learning styles, visual, kinesthetic, and auditory, so that both children and adults could benefit. We produced a video with closed captions and multilingual voiceovers, ensuring inclusivity and for non-English speakers, those with hearing impairments. In some materials, we incorporated faith-based metaphors to align with the values and traditions of the community, making the message more relatable and accepted. The video was done on my phone. For competency C18, I focused on evaluation and quality improvement. This included tracking engagement metrics, collecting feedback from both caregivers and community health workers, and identifying ways to improve materials for future use. We used both pre- and post-intervention surveys to measure changes in knowledge, attitudes, and reported behaviors. This allowed us to see clear improvements in brushing frequency and increased interest in preventative dental visits. This experience solidified my ability to translate public health theory into real-world practice. The toolkit we developed has already contributed to measurable behavior changes in the community, managing translations, coordinating with multiple stakeholders, and navigating cultural nuances, strengthened my project management and leadership skills. Perhaps most importantly, APE deepened my commitment to pursuing a career focus on community-based oral health promotion and health equity. I'm confident that the lessons I learned here will continue to shape my approach as I move forward in my public health and dental career. Before closing, I would like to highlight the appendixes, which provide my supporting materials and data behind this project. So Appendix A here we see contains the needs assessment, summary, and survey results outlining the most common barriers to care, such as language, cost, scheduling, transportation, and dental anxiety, with clear percentages from our participant groups. Appendix B, which is on the bottom, showcases that the multilingual flyer Health Smiles for Every picture, which was distributed in 5 languages, which is so that we can reach diverse community members and people who don't speak English, perhaps. Appendix C includes the workshop agenda and education handout used to guide our in-person sessions on brushing techniques, fluoride use, and nutrition. Appendix D here presents the survey analysis featuring a visual breakdown of barrier prevalence and narrative summary of open-ended feedback from our participants. Most of the things on the top show Appendix D, and then on the bottom it shows Appendix E. Finally, Appendix E contains translated handouts and facilitator scripts in 5 languages, all designed and reviewed for cultural linguistic appropriateness, as I kept saying, and these appendixes are meant to demonstrate not just the outcomes, but concrete tools, materials, and evidence that shape this culturally tailored oral program. I would like to thank you for paying such close attention to my presentation, and I really appreciate you staying till the end. I know it was a lot, but hopefully I got you to think about your next dental visit at least. And if you haven't scheduled your next dental exam or cleaning, make sure you call your dental office tomorrow to schedule that. But here are my references. I just want to thank you so much, and I hope you have a good day. This was my presentation. Good luck in your journey.